Hello friends, hi, I'm Dr. Shonali. Welcome back to our YouTube channel that is Medicine Decoded. And like I promised you in the last video that I'll be taking up a discussion on beta-thalassemia and discuss the pathology and how it is different from iron deficiency anemia. Now, let us get started without wasting any further time. Let us just briefly talk about what thalassemia actually is. Now, thalassemia is a genetic disorder, right, where there is mutation in the globin gene, right, and we inherit that mutation from either of our parents. So if we ourselves are carrying that mutation, we can transmit it to our offsprings as well. Right now, the adult hemoglobin which is present in our body is predominantly hemoglobin A, that consists of 2 alpha chains and 2 beta chains. Right now, the gene for this alpha chain is present in chromosome number 16, and the gene for this beta chain is present on chromosome number 11. Now, various kinds of mutations have been described, being point mutation and chain terminator mutations. So there's a whole lot of mutations that are described. The point being that these mutations are inheritable. Right now, the other form of hemoglobin which is present in minor amounts in the adult blood is hemoglobin A2, which is alpha 2, that means 2 alpha chains and 2 delta chains. Right, and then the other minimal amount of hemoglobin that we have is hemoglobin F, which is the fetal form of hemoglobin. That means it is the predominant hemoglobin in the fetal life, right, but not in adult life, that consists of alpha chains, that is 2 alpha chains and 2 gamma chains. So that is a broad description of what hemoglobin is all about. Now, the thalassemias can be grouped into 2 broad types depending upon which chain has been affected by the mutation. Right? So when the mutation is in the alpha chain, we get the alpha thalassemias. When the mutation is in the beta chain, that means chromosome number 11, then we get beta thalassemias. In our discussion today, we are focusing more on beta thalassemias. So let's just get going and talk about beta thalassemias here. Now, beta thalassemia is predominantly occurring in a belt of countries like the Mediterranean countries. We have beta thalassemia is common in the Middle East. We have it in the Indian subcontinent as well, and we have it in the Southeast Asian region as well. If you talk about countries like US and UK and Western countries, then immigrants of these regions to those countries are at more chances of finding beta thalassemia in them. Occurrence of beta thalassemia, inheritance and mutations are more common in those set of populations. If you talk about the Indian subcontinent particularly, then the North Indian belt, particularly Punjab, Haryana, Rajasthan, Delhi, Uttar Pradesh, and your Goa and parts of Maharashtra as well. They are the regions where beta thalassemia is more common. And if you talk about broadly in India, the incidence of beta thalassemia is about 5 to 15%. There's this huge range. Now, having said that, beta thalassemia or identification of beta thalassemia particularly becomes important for those of us who are living in these regions, and also for practitioners who are finding these people now as immigrants in their situations. Now, beta thalassemia can be of 3 forms broadly. I've just written 2 forms here for simplification. One is beta thalassemia major. One is beta thalassemia minor, which is also called as thal trait or thalassemia trait. And there's an intermediate form also, which is beta thalassemia intermediate. Right? Now, see, there are 2 set of copies that we are inheriting from both our parents, right? So one beta globin gene from one parent, the other beta globin gene from the other parent, right? If we inherit both the abnormal copies of the genes, making us homozygous to the abnormal mutated gene, then we get beta thalassemia major. In that, what will happen is, because there will either be complete absence or minimalistic formation of beta chain altogether, right? So there will be complete absence or a very severe deficiency of beta chain formation. And that will result in severe anemia, right? And it will be severe to the extent, right, that they will exhibit many such pathological processes which I'll describe in the next slide. Apart from that, these people are regularly dependent on blood transfusions, repeated blood transfusions, to maintain their hemoglobin levels. Right? And if you ask me, as of now, the most effective therapy for beta-thal major is a stem cell transplantation in life, but we're not going into those details as of now. But nonetheless, severe anemia and regular blood transfusion characterize beta-thal major, and we'll discuss the other pathological problems as well. Now, considering beta-thal minor, which is the trait, it's heterozygous. By heterozygous, we mean that one has inherited a normal copy from one parent and an abnormal copy from the other parent, right? So, the beta-thal minor will show only little decrease in the beta globin chain synthesis. There will not be complete absence or a severe deficiency. So, these people who are heterozygous or with beta-thal trait, they are usually having either a mild anemia or they are entirely asymptomatic, and they don't manifest the various pathological processes of beta-thal major, and then intermedia is in between the two in terms of severity. Now, moving on further, let's talk about the pathology of beta-thalassemia. Now, bone marrow is the site of RBC production. We know that, right? Now, in the bone marrow, we have what will happen is the erythroblast production takes place during the red blood cell formation. And what we'll get here are abnormal erythroblasts. They are abnormal. Why? Because there is an entirely deficient, beta globin chain synthesis on one hand. Right? So, hemoglobinization, proper hemoglobinization of the RBCs is affected, right? And secondly, there is an excess of alpha chains. You see, alpha chains have to combine with beta chains to form a complete hemoglobin, right? Now, there is deficiency or complete absence of beta chains. So, the alpha chains are unbounded. You see, and that leads to alpha globin aggregates, alpha globin chain aggregates in these erythroblasts, in the cytosol of these abnormal erythroblasts, right? Now, most of these abnormal erythroblasts are actually going to die, right? Leading to a situation of ineffective erythropoiesis. So, the red blood cell formation, that is erythropoiesis, is happening, yes, but it is ineffective. It is not terminating well, right? Now, some of these abnormal erythroblasts will also enter the circulation, and then we will get these microcytic, smaller in size, under hemoglobinized, hypochromic RBCs in the circulation, right? Now, these microcytic hypochromic RBCs, apart from being microcytic and hypochromic, they also have these alpha globin chain aggregates in their cytosol, promoting cell membrane damage of these circulating RBCs. So, when cell membrane damage supervenes, then these erythrocytes, these RBCs, they become prone to hemolysis and destruction, right? So there is an increased extravascular hemolysis that takes place in the spleen, right? And therefore, consequently, you will realize that the lifespan of the RBCs decreases. They don't survive for very long in the circulation. So all of this together, ineffective erythropoiesis, some amount of extravascular hemolysis, a decreased lifespan of the RBCs in circulation, it all contributes to anemia. Right? Now, let's go a little bit deeper and figure out what else happens with ineffective erythropoiesis, right? Now, this pathology is going to be at the set of extreme, one set of extreme, a severe disease in case of beta-thal major. In case of beta-thal trait, there might be only minimal amounts or minimal degrees of ineffective erythropoiesis and not significant extravascular hemolysis. So the pathology is going to operate, in the degree of severity, depending upon whether it is thal major or whether it is a simple thal trait. Now, moving on further, what happens because of ineffective erythropoiesis leading to anemia? So anemia, if you understand what exactly anemia is, obviously the basic definition, hemoglobin concentration decreases and so because the oxygen carrying capacity of the RBCs is also going to decline because of that. And ultimately, it's actually going to lead to tissue hypoxia. Right? So the peripheral tissues are not going to get their fair share of oxygen. Right? So tissue hypoxia, and hypoxia in the tissues, there will be hypoxia, in the tissues of the kidney as well. Now, hypoxia is a very, very important trigger for erythropoietin production. You see, our body responds to hypoxia. How so? It tries to increase the red blood cell formation, isn't it? Because on one hand, the demands for oxygen are not being met. So to meet those demands, our body responds by increasing this hormone production, which is erythropoietin, EPO. Increased erythropoietin coming from the kidneys, leading to bone marrow expansion in the body, right? So marrow expansion. And it is this marrow expansion, you see, if you consider the bone, you see, the inside of the bone, the center of the bone is rich in marrow. The bones of the skull, they also have marrow. So what is important to note here is that when marrow expands, it will erode or eat up into the surrounding cortical bone, giving rise to bone deformities or skeletal deformities. Bone deformities or skeletal deformities. So children who have inherited this beta-thal major, you often find them to have, a stunted growth, and they have abnormal long bones. They also have, these prominent cheekbones, the marrow expansion in the zygomatic arch, the marrow expansion of the skull bones. So that kind of a classical appearance, phenotypic appearance is also there. Now, the extravascular hemolysis is also taking place in the spleen, and marrow expansion sometimes may not even be sufficient to meet meet the deficiency of hemoglobin in these patients. So sometimes when there is a severe thal major, you see, there can also be other sites in the body which take over the production of RBCs. Now everybody has come to help. So that is like what we call as extramedullary erythropoiesis. Now, other sites have also come to help the bone marrow in increasing the red blood cell production, like the liver like the spleen, right? So initially what will happen is these individuals, these people who have inherited beta-thal major, they will have hypersplenism, they will have enlarged liver, hepatomegaly, and eventually the spleen, gets tired of its activity of, hypersplenism, and ultimately, what will happen is that, because of hypersplenism, there's a downside to it. You see, the extravascular hemolysis is also taking place in the spleen, so that is a dangerous proposition. Now, moving on further, what happens in case of ineffective erythropoiesis, which we discussed when we were talking about iron metabolism as well, that this is sensed by the liver, and the liver increases the secretion of hepcidin, sorry, decreases the secretion of hepcidin. Now, when the hepcidin secretion is decreased, we have all discussed what happens, right? Hepcidin secretion decreases and there is increased iron absorption from the gut, right? And that leads to iron overload. Very, very important point to note. So they don't have deficiency of iron, mind you. They have excess of iron in their stores. They have iron overload. It can become severe to the extent, iron overload in the reticular endothelial system, iron overload in the spleen, iron overload in the liver, iron overload in the pancreas, iron overload in the tissues of the heart. So it becomes a multi-organ dysfunction kind of a state, right? So what happens is what we call as secondary hemochromatosis. Right? Excess iron now will be stored as hemosiderin. So what we reach here is a state of secondary hemochromatosis. Right? Now, another very, very important point to note here is that these people who are, or these children who are having beta-thal major, they have all these pathological findings, and in spite of the body adjusting its, iron absorption, the body adjusting its erythropoietin and trying to increase the red blood cell formation and everything, all these pathological processes like marrow expansion, extravascular hemolysis, and extramedullary erythropoiesis, it is not enough to sustain them. Moreover, it is also leading to the other problems, bone deformities, you see, and hypersplenism, hepatomegaly, and deposition of excess iron in the liver, pancreas, and the heart, leading to cardiac dysfunction, leading to pancreatitis. So there are a lot of problems that can ensue, and these people are dependent on regular blood transfusions to deal with this anemia. This is the problem. This is where it all started, isn't it? This is where it all started. So to deal with this anemia, they get regular blood transfusions. When you give regular blood transfusion, you counteract the tissue hypoxia, right? That's over now. When you give regular blood transfusion, since you have counteracted the tissue hypoxia, you start dealing with the erythropoietin. There is no more increased erythropoietin production, right? So giving regular blood transfusion decreases tissue hypoxia, decreases the erythropoietin production, and deals with the other eventualities that will happen. The downside of this is that even if you give excess regular blood transfusions, you will lead to iron overload. So apart from regular blood transfusions, you see these children, they are often needing iron chelating agents, right? Agents like desferrioxamine, which are going to be taken, right, as a treatment protocol, and these are going to chelate or bind to the iron in circulation, excess iron in circulation, and eliminate it, right? So iron chelating agents are often required in their treatment. And yes, of course, the definitive treatment for beta-thal major will become a stem cell transplantation to begin with. Now, the other thing is, in beta-thal major, what also happens is, look at this person here, a drooping fellow, a drooping stunted child, right? He has severely cachexic, right? On the one hand, the tissues are hypoxic. On the other hand, the marrow, the excessive erythropoiesis, all of this is stealing away the vital nutrients from the rest of the body, right? Stealing away the oxygen, stealing away the vital nutrients from the rest of the body, resulting in a severe cachexic state as well. So this is the basic pathology of beta-thalassemia. This is what happens. And how is it different from iron deficiency anemia? First of all, there is no iron deficiency to begin with. In fact, there is iron overload that can happen, right? There is anemia. There is tissue hypoxia. That's there, right? There is a blood picture of microcytic hyperchromic anemia. That's also there. But the reason for this anemia is entirely different. The reason for this anemia is an ineffective erythropoiesis and extravascular hemolysis, right? So with this, we are all set to answer the next question. That is, how beta-thalassemia trait confuses our diagnosis of iron deficiency and vice versa, and how can these two situations be differentiated, and we'll talk about that in the upcoming video. Thank you so much.